population due to its significant effects on them. Anyway, this is just a brief summary. British Medical Journal, September 1978, talking about the National Poison Information System, and talked about how this low-dose pill, 0.25 milligrams of clonidine used for migraines and a variety of other nostrum kind of things, was lower than the blood pressure lowering catapress and produced a significant problem in children, and some packaging changes occurred as a result of that. So what's real familiar to us, I think, is this is a summary from Archives of Pediatrics. Just looking at, what I think all of us know is clonidine is a pediatric ingestion for the most part. It's become not so much a hypertensive medication, but an anti-hyperactivity drug, and therefore we see the older child in school feeding it to the younger child or leaving the bottles around. The good news, when we look at this data, is that even though there's a lot of children under 6 taking this drug, the number of deaths are incredibly small and almost never happens in anybody over the age of 6. But there are major outcomes, and those of us who have been working for years pretty much know that probably not a week or two goes by without us hearing about some kid being transferred to a pediatric ICU with a clonidine ingestion. And usually therapy's been supportive. But clonidine is not the only thing we need to worry about. There's other drugs that have come along. Guafacine has come along as a second-generation alpha-2 agent used for ADHD. Here's a brief paper, one talking about how you get initial hypertension, which is also well known with clonidine, and then subsequent but delayed persistent hypotension that can occur as well. Besides the ADHD drugs, there's other things I think we need to worry about. This was an interesting article reviewing bromonidine, and we had a case of this early on when I first started here. Bromonidine is an ophthalmologic preparation called Alpragen is the trade name. It's a pretty popular glaucoma drug, and you'll see they're very structurally similar and pharmacologically identical, and perhaps even more potent than clonidine itself. And we see this in children because those nice little eyedropper bottles have no child safety protection on them, and they look like little baby bottles, and they squirt a few drops of that in their mouth. And the usual side effects that we see described for clonidine and guafacine happen in children as well. The peak ages are the toddler exploratory ages. The chief side effects that we see are bradycardia and hypertension in a certain percent, with occasional transient early tachycardia and hypertension, which we see as well. To kind of round out the list of things that happen at alpha-2 that are somewhat exotic, there's a veterinary preparation, and we'll get back to veterinary practice towards the end of this session, but Ramapan, which is xylazine, is used in veterinary anesthesia, and the vets may have a trick up their sleeve that we don't, but we'll get to that. The other thing we see occasionally is in the list of useless drugs for muscle and back pain, we have the drug Zanaflex and tizanidine, which I always lump these things together as sort of a nonspecific sedative drugs used for muscle relaxation, but in fact this specific one is an alpha-2 agonist like all the other ones we've talked about today, and it too produces the same triad of altered mental status, bradycardia, and hypotension, and occasionally we're plagued with adults who are taking these in excess. So in summary, the central alpha-2 agonists that we know about are clonidine, which comes in pills and patches. The variety of ADHD drugs like guafacine and guanabens are kind of like the name Intuniv, to get you in tune for school. And then there's a variety of eye drop combinations out there. I also want to mention the other little eyedropper kind of things that all act at the same receptor, oxymetazoline, which is an Afrin, and Visine, and Nafzolin, which is an Nafcon. Again, kids get into these because they're little baby bottle-sized things you can squirt in your mouth and get yourself a significant overdose of these potent imidazoline-acting agents. So to start out of our what's new at alpha-2, I'm going to turn things back over to Rob and talk about a drug that some of us are becoming much more familiar with in the ICU, but this may be a novel ER use for this drug.
Great, thanks, Shane. So when we we're going to start our papers now, the 3 papers that we sent out to you. I do want to remind everyone that if you have a comment, you're all muted, so if you want to say something, you have to raise your hand. We will unmute you, and then don't forget to put your hand down so that we know that you're raising it again. So if you have any comments, if you want any comments at all, this is really intended to be interactive, and we really encourage anyone, if you've used one of these medicines, if you have a personal experience or you want to throw in a little tidbit, please just raise your hand and we will we'll do our best to multitask and to notice and call and unmute you. So I'm going to talk about intramuscular dexmedetomidine sedation for pediatric MRI and CT. This was published in the American Journal of Röntgenology not too long ago, a couple of months ago. So I just want to give you some background on dexmedetomidine, I think also known as Precedex, and I think some of us are very, very familiar with it and others probably are not. It is a specific alpha-2 agonist, much like the medicines we've been talking about already. There's also some evidence that it probably binds to the I1 imidazoline receptor, but those clinical effects are not entirely clear. It's been approved for quite a while for IV sedation of ventilated patients, but more recently, a couple of years ago, it was approved for sedation outside the ICU. And there's been a bunch of studies using an IV, nasal, buccal, subcutaneous, and then also in the IM route in adults, but there hasn't been a previous study using an IM in pediatrics. So the effects are an interesting anesthesia that's been called cooperative anesthesia, and what that means is they're very, very sleepy, but if they are stimulated, they will open their eyes and follow some very basic commands, and then go back to sleep. It also has some amnestic and analgesic properties, and just as with clonidine and the other alpha-2 agents, the main side effects are hypotension, bradycardia, and the possibility of a transient hypertension before the hypotension, much like we've seen with large clonidine overdoses. This is probably only with large doses of dexmedetomidine. So this study was really looking at the idea that infants and children commonly need sedation for MRI and CTs. I think we'll all agree on that. Interestingly, authors note that the most common agents used worldwide are chloral hydrate and pentobarbital, which I thought was fairly interesting. I think in the U.S., mostly people are using propofol and ketamine, midazolam, and nitrous oxide, and a few other agents. I think those are the most common ones. But there's no previous reports of IM sedation with dexmedetomidine in children, and there's obvious benefits for not having to place an IV in a child in order to do a sedation for a radiologic procedure. So these authors did a 26-month retrospective review of their dexmedetomidine pediatric sedation protocol, and this is at Boston Children's Hospital. So it's important to know this is not a study, this is what they do, and they're just reporting what they do. But their protocol was basically they put 4% lidocaine patches in the form of LMAX patches on both deltoids. They gave an IM dexmedetomidine dose by a pediatric nurse practitioner and then supervised by a pediatrician. And you see the exclusion criteria on the left there. They're actually fairly interesting, and they're based on the expected effects of dexmedetomidine. They excluded people who they thought would be dangerous to cause bradycardia in, people with long QT syndrome and current use of DIDs. They excluded people who would be bad to have really bad hypertension, and they excluded people who had thrombocytopenia and coagulopathy so that you shouldn't give an IM injection. And then, of course, difficult airways they excluded as well. The dose was 1 to 4 mics per kilo, and you were allowed to give a second dose at 10 minutes that was reduced. And the criteria for using that second dose was a Ramsey score that was not greater than 4, and you can see the Ramsey score on the right. It basically means that they're asleep, but if you touch them on the forehead, they open their eyes. Or if you yell at them, they open their eyes, auditory stimulation. So then they monitored them, they did the study, and they put them to a recovery unit, and they used pretty traditional pediatric sedation DC criteria. So they had 65 patients. 21 got an MRI, 44 got a CT scan. The mean age was between 2 and 3, but they had a range from a month to 10 years, and they were mostly boys. And it's important to note that this was a tertiary/quaternary care center, so there's a very high percentage of encephalopathy and developmental delay and macrocephaly. But interestingly, all children completed their imaging, so there was not a single failure of sedation in the entire group. You can see that the total doses were between 2.9 versus 2.4 mics per kilo. A little bit more in the MRI group, which kind of makes some sense if you wanted them to be a little bit more sleepy for a longer study. First dose is about 2.5 mics, second dose is 1 to 1.5, and only 4 patients out of the total of 65 needed a second dose. Time to sedation was 13 minutes, which is consistent with a pharmacologic study in adults that saw a time to peak of 12 minutes. And interestingly, the duration of sedation was very different. MRI group was 60 minutes, and the CT group was 33, and that was almost entirely explained by the change in the procedure length. So the authors sort of posed the question, why did patients with similar doses have much longer sedation with an MRI? And their hypothesis was that it was because of this cooperative anesthesia. If you're in the MRI machine, it's not making particularly loud noises like they sometimes do, and you're not being stimulated, you'll remain asleep, but the people who got the quick CT then went back to the recovery unit, got stimulated by the people who were watching them recover, and got blood pressure inflation and things like that, and that's why they woke up. Interesting theory. I don't know if that's entirely true or not. But. So the big question is what happened to the vital signs, and the x-axis here is age groups, and the y-axis is heart rate, and note that it doesn't go down to 0, so these are not proportional changes, but then you can see that they had no cases of significant bradycardia. So the boxes here are the age-related normals, and the hash marks are a 20% reduction in the age-related normal. So they did have some kids that were lower than normal. They didn't consider it bradycardia, and interestingly, they were all in the 0-3 month group, so there may be some significant age-related differences in toxicities from this medication. They did have 14% rate of hypotension. Again, this seemed to be age-related in the sort of 1 to 12-year-old group, and not in the kids less than 1-year-old. And of note, all the patients who had hypotension, it resolved spontaneously within 10 minutes without interventions at all. So I think this study is an interesting one. It shows that this protocol is probably effective, although there are some issues with hypotension. I think the point here is that we'll probably be seeing more of dexmedetomidine, and those of you inpatient or ICU-based toxicologists out there, I'd be very interested to hear if you're using dexmedetomidine. For the poison center-based toxicologists, I'm curious if you've gotten the same question that I've gotten is, hey, I've got this person with alcohol withdrawal, can I use dexmedetomidine? I've got this person with practically any condition whatsoever, can I use dexmedetomidine? So kind of curious to hear other people's experience with this drug and whether you're using it in your inpatient service. So I don't see any hands up. We're happy to unmute you if you have any comments, but I'm going to continue. Let's talk about something that is, we have a hand up. Phoenix?
Can you hear me?
We can.
I only put my hand up because you said you wanted feedback and then you were moving on, so I took it down.
Sorry about that.
To say that, this is a really interesting use, IM sedation in pediatrics, but for our ICU, we really don't use dexmedetomidine on our service. For one thing, it's pretty expensive, and I'm not sure that we've really found a need or a use for it. We manage a lot of alcohol withdrawal, and we use benzos, and if we don't have good success with benzos, we'll start with small doses of phenobarb, and we're pretty universally successful with that, I think, and I just haven't found a need for dexmedetomidine. And the studies that I've seen, even some of the ones that, were preliminary, not accepted yet to journals that I reviewed, really haven't compelled me to try it for alcohol withdrawal.
It's interesting. I've gotten that question several times, and I'm not sure why. I think there's a couple of really small studies that are kind of convincing people to give it a shot. But it might be one of those new drug effects. Everyone wants to try the new toy.
Right, yeah, that's what I'm wondering. But this study was interesting.
Well, thank you. And if anyone else has any comments, we'll just pause a second and see if anyone else wants to share their experience. All right, so we're going to move on to something that we see a little bit more often than sedating pediatric patients for radiological procedures. We'll talk about a drug that's been around for a long time, and we certainly see a fair amount of. And according to the slide up there, it not only kills dandruff, but it also increases the growth of your hair. So, and it only costs 15 cents, which is pretty cool. So we're going to hand it over to Ben Hatton.
All right. So this is a paper out of Dallas, and they are looking at options for treating cocaine intoxication, acute cocaine intoxication. A little bit of background: 34.9 million Americans have tried cocaine, and about 7.3 million are regular users, and they report 15% of young adults 18 to 25 are users of cocaine, and it's the primary illicit drug that causes cardiovascular emergencies. Kind of review the standard theory of why this occurs is blockage of norepinephrine reuptake in the peripheral sympathetic nerve terminals. And then you have excess norepinephrine in the synaptic cleft, and that results in all the sympathetic overload that causes the toxicity. However, they propose that there is an alternative mechanism, and there are some recent studies that they've performed that tend to show that cocaine stimulates the cardiovascular system by acting in the brain to increase central sympathetic nerve activity. And that's the neural stimulus to norepinephrine release, and there's minimal contribution from peripheral norepinephrine transporter inhibition. So their thought is if we can block this central sympathetic nerve activity, then potentially we can alleviate the peripheral effects of cocaine. So there have been some prior studies on using clonidine and other alpha adrenergic receptor agonists in animals, but they haven't tried it in humans in cocaine. So the goal of this study was to test whether they could control cocaine-induced central sympathetic activation with dexmedetomidine and reverse the acute hemodynamic responses to cocaine. The other goal was to see whether this activity was applicable in a general population, specifically in a multi-ethnic population that commonly has a specific mutation in their alpha-2 receptor, the alpha-2C deletion 322-325, and I'll just call it the mutation from now on. So, it's primarily an African American population, which necessarily coincidentally is the population with the highest cardiovascular mortality in the U.S., and this mutation's been investigated in heart failure and other cardiovascular pathologies. So it's a fairly small study, but they packed a lot in. They had one group that was 15 subjects, and these subjects were randomized, all given cocaine and randomized to either be treated with dexmedetomidine or saline. If you notice that there were 15 subjects, but 19 people got randomized, that's because 4 people came back for more and got randomized twice. And then the second part are 7 subjects who were selected from a larger Dallas heart study that were all positive for the mutation, but met all their exclusion criteria. So specific inclusion criteria were patients had to be normotensive, no history of cardiovascular disease, cocaine abuse, or other recreational drug abuse. Nobody could be taking any prescription or non-prescription drugs with cardiovascular autonomic effects. They measured, in the study, they measured the observer's assessment of alertness and sedation score to see whether dexmedetomidine causes significant sedation at these doses. They also measured peripheral nerve activity using a perineal a measurement of the peroneal nerve, and then they also measured skin blood flow. And can you go on to the next slide? Sorry. So this is a graph demonstrating the nerve activity, the peripheral nerve activity. You can see the spikes on the left. The upper left is the baseline, and then just below that is cocaine, and then you see cocaine plus dexmedetomidine, and then a little bit later cocaine plus dexmedetomidine. And then on the right is controls with saline. So specifically their procedure was to instill 2 milligrams per kilogram of 10% cocaine in bilateral nostrils, so for a total dose of 2 milligrams. They had obtained baseline measurements, and then they looked at results up to 90 minutes. They waited 30 minutes to initially randomize, and that would be the peak effect of cocaine, and then they're randomized to either a single IV bolus of dexmedetomidine, and that was at doses of 0.1 and 0.3 mics per kilo over 1 minute, or saline at the identical volumes. And they waited 10 minutes between the doses of drugs. And they did the same protocol on the patients with the mutation, but they didn't have a control group. They only did the dexmedetomidine group. So results. If you see the box on the left is the comparison between the two groups in part 1. So you see the results that are falling off the cliff. That's all the skin sympathetic nerve activity drops off markedly after the dose of dexmedetomidine, whereas the saline group basically is level. There's no effect on the nerve activity with saline. The box on the right is the same tracing of the group that got dex in part 1, and with the addition of a tracing of the group with the mutation. And it's just to show that basically there's no difference in those two groups, that the mutation didn't affect the skin nerve activity. Go on to the next slide then. So, and these results are laid out in a pretty large table, but essentially results were significant when compared with saline groups and from baseline for most outcomes, and that includes MAP, heart rate, skin nerve activity, skin blood flow, skin vascular resistance, and there was no effect on the sedation scale. So this dose of dexmedetomidine does not cause significant sedation. And so their conclusions were that this works, it's effective and safe, and that it also works in groups even if you are homozygous for this loss of function mutation. And their thought is that there are multiple alpha-2 receptor subtypes, and that potentially losing one won't have that significant of an effect on activity globally. And they do have some limitations. This is a very, very small study in a controlled setting. They also used very small doses of cocaine, or relatively small doses of cocaine, roughly in the range of 1 to 2 lines probably for the street user, so less than what somebody typically uses in one day. And it's also, they specifically selected people who aren't habitual users of cocaine, so they don't have a way to tell whether these same effects would occur in chronic users. And then they also only looked at cutaneous circulation and skin sympathetic activity, and they don't know whether these same effects are seen in the human coronary circulation and some of your central sympathetic outflow tracts. So clinically, this may not be as relevant. But food for thought as a novel treatment for cocaine intoxication.
Yeah, any questions or comments from the assembled multitude out there? I'll just say, I thought it was, as we look into the future of drug development, and one of my roles is PNT, I think it's good to look at how drugs affect people differently with different genomics and proteomics and all these other novel things. And I think it was very interesting in this article that they found this mutation that's highly prevalent in the population that actually has low sensitivity of the alpha-2C, this A, B, and C alpha-2 subtypes, which may be a new or novel degree of understanding of the subtype. Certain people have a low receptivity of the alpha-2C version, yet this drug didn't seem to be less effective in that group. It also doesn't seem to affect their level of consciousness, so I think this is an issue where you have someone who has all the bad side effects of cocaine. They're having chest pain or EKG changes or hypertension, and of course you don't want to give them a beta blocker, but this may be an option to get all that sympathomimetic hyperactivity under control without really sedating them at lower levels, at least the dexmedetomidine doses that they use, and could be titrated up. And
so one caveat there, they mention it in the study, and there's at least one older dog study that showed increased peripheral vasoconstriction with the use of dexmedetomidine in cocaine intoxicated animals, and the theory was that the initial bolus dose causes non-selective alpha agonism, and you initially will get some vasoconstriction. So if you're already kind of teetering on the edge, then that could potentially tip you over. That may be dose related, and not entirely sure.
Any questions from all the folks out there listening in? Yeah, areas with more cocaine than we have out west.
Our druggies prefer.
But are you sticking to our tried and true standard of tons of benzos, or has anyone even considered using Precedex for this indication? Okay. All right, I'll take that as an accumulative, not sure yet. But this is always the case with new drugs. I think they wait until you find their role and pharmacology. This is why I think we like to review some of these. So even jumping a step ahead, wouldn't it be nice if we're going to start using a lot of dexmedetomidate, that if we somehow titrate a little on the high side, that we had a way of reversing that and backing off? And so I will turn this last article over to Shannon Friedman, our other fellow.
All right, so I am going to be presenting this paper actually came out of Finland in the Journal of Anesthesiology in 1998 about using a reversal agent, atipamezole, with dexmedetomidine. There's a little bit of background that goes with this paper and why I'm presenting it. One day we were on rounds, and I got a text message from my sister-in-law, who is a veterinarian, saying, "You'll never believe what happened. Your great-uncle Sherman's dog got into his clonidine." And so we're sitting here rounding, and I'm getting these minute-by-minute updates about Uncle Sherman's dog at the veterinary office that's bradycardic and hypotensive. And all of a sudden, Paige, my sister-in-law, says, "Great news, I reversed the clonidine using atipamezole. Isn't that great?" To which I responded, "What's atipamezole?" And it turns out in veterinary practice, they pretty routinely actually use dexmedetomidine to sedate animals for procedures. And they use atipamezole immediately after the procedure to reverse, Uncle Sherman's dog or whoever's dog, and then they send him right on home, and it's used pretty successfully. So not having heard about that drug, we kind of started talking about it on rounds and turned up this paper that is a little bit old, but interesting for a number of reasons. So the background that the authors present for why they did this volunteer study was that, I guess, in Finland, dexmedetomidine is becoming pretty popular, and they found it to be 10 times as selective for ACID-2 when they compare it to clonidine. There are some small studies looking at it being used at this 2.5 microgram per kilogram IM dose in clinical settings, particularly in the operating room. It's been found to be equivalent to a dose of 0.07 to 0.08 milligrams per kilogram of midazolam, and it's felt to be pretty useful in surgery. There are concerns about it lasting longer than desired, and a sort of push towards having a reversal agent so you can wake your patients right up and have them leave. Atipamezole has been used pretty widely and successfully for this in veterinary practice. There are some small studies looking at it in humans, so they wanted to take a look and see if this was really a viable option. They had 4 specific objectives in their little study here. The first was that they wanted to determine an effective IV dose of atipamezole to reverse the 2.5 microgram per kilogram IM dose of dexmedetomidine. They wanted to assess for the reappearance of effects from dexmedetomidine after atipamezole wore off. They wanted to look for pharmacokinetic interactions between the 2 drugs. And finally, they wanted to evaluate the safety and tolerability both of dexmedetomidine for sedation and of atipamezole as a reversal agent. So as far as their study, they had 14 volunteers total. They were all healthy men, aged 20 to 28, normal weight, no medical problems, not on any long-term medications. And they did a 2-part study. The first part was an open-label dose-finding portion where they calculated what they felt would be an effective reversal dose of atipamezole. The second portion was a placebo-controlled crossover blinded study of 3 different doses of atipamezole, which I'll talk about later, and saline, given in random order, after administering dexmedetomidine. And they spaced those assays out by at least 7 days to make sure that they had enough time for the drugs to wash out. The general procedure they followed was they had their subjects fast overnight, and they weren't allowed to drink alcohol for 48 hours. In the first round, the dose-finding portion, they told the subjects they were going to be getting sedation, and then they told them that they would be getting a reversal agent, and that they should verbally communicate when they felt awake enough that they didn't think they were sedated. The reversal agent, atipamezole, was given at a dose of 12.5 micrograms per kilogram per minute, and basically recorded how long the drug was running in from time of start of infusion until the subject said they felt awake, and then they would use that as their total dose that individual received. In the second round, when they were trying different doses of atipamezole, the subjects would get a 2.5 microgram per kilogram IM dexmedetomidine injection, and then 1 hour later would get either a 15, 50, or 150 microgram per kilogram dose of atipamezole, or they would get saline. They would then be observed for 6 hours, and a number of parameters would be observed, specifically vigilance and anxiety, which was recorded on a visual analog scale, psychomotor performance, which was tested using a digital symbol substitution test, saliva secretion, which was probably uncomfortably tested by placing cotton balls in the subject's mouth and weighing them. And they also were monitored hemodynamically. They were placed on telemetry monitoring and had systolic and diastolic blood pressure recordings taken at pre-specified intervals. In addition to this, they went ahead and took advantage of the opportunity to do some blood assays as well. They measured serum norepinephrine, epinephrine, and DHPG, which is a metabolite of norepinephrine levels, throughout the test at pre-specified times. They also measured dexmedetomidine and atipamezole concentrations in their subjects at pre-specified times. So as far as the results, part 1, the dose-finding study, basically what they found, first of all, was that dexmedetomidine worked great for sedation. All of the subjects fell asleep, and all were easily woken for the assessments that were needed, kind of similar to what Rob was saying earlier about one of the interesting things about this drug is that when you use it for sedation, you can have this sort of cooperative anesthesia. The mean dose they found that was needed to reverse sedation from dexmedetomidine was 104 micrograms per kilogram, plus or minus 44. The range spanned 50 to 163 micrograms per kilogram. In all cases, after the subjects said that they were awake for the remainder of the observation period, they were felt to be awake by the visual analog and various other assays they were doing, so they felt that these were pretty reliable reversal doses. based on this 104 plus or minus 44, that's how they calculated their doses for part 2. Basically, 15 micrograms was 1/10 of what they felt to be a wake-up dose, 50 was 1/3, and then 150 micrograms per kilogram was the full dose. So as far as their success with atipamezole and dexmedetomidine, this figure here, give me this one, this is sort of the first set of results. I'll try and go through all these various graphs as quickly as possible because I think they're a little dry. This slide shows the results for the vigilance and anxiety monitoring. The top graph, graph A, shows the vigilance results. Basically, the different lines correspond to increasing doses of atipamezole. So what they found was the highest dose, the 150 microgram per kilogram dose of atipamezole, completely reversed sedation to baseline, and once it was given, the visual analog scores remained high until the end of the observation period. They found that the difference between giving the highest dose and the next highest dose, between 150 and 50, was significant. The difference between giving 15 micrograms and placebo was not significant. The bottom graph, which shows the anxiety scale results, showed that, dexmedetomidine definitely decreased anxiety levels, and the only significant result they found was that the higher dose, the 150 micrograms per kilogram, increased anxiety ratings above baseline by about 100% initially, and then it settled down. The remaining results were not found to be statistically different from giving placebo. This next figure shows the results for the digital substitution testing and the saliva testing. The top graph looks at the results from this sort of basically digital substitution with symbols testing they would wake patients up and make them do. They found that dexmedetomidine definitely decreased performance on this test, and for some reason the performance was a little bit worse in the 15 microgram per kilogram group at baseline. In general, subjects did better on this test in sessions 2 through 4 than they did in their first one, regardless of where they had been randomized, so they felt there was a little bit of learning which went on across the assays, so this one wasn't considered as reliable. They did find a significant treatment-time interaction and time point comparisons. The bottom graph is the saliva secretion test. They found that dexmedetomidine definitely reduced saliva in all of the subjects, and the highest dose of atipamezole completely reversed this. It was slightly reversed by the 50 microgram per kilogram dose, and no difference in saliva secretion was found in the lowest dose or in the placebo group. The next figure shows the results of the hemodynamic monitoring. They found that dexmedetomidine administration did significantly reduce systolic, diastolic, and heart rate in all of the subjects. This was generally in the range of about 10 to 15%. Blood pressure is on the top graph, and heart rate is on the lower graph here. They found that atipamezole significantly and dose-dependently reversed all of these changes, and the higher dose, 150 micrograms per kilogram, slightly overshot. At both the 65 and 75-minute mark, blood pressures were a little bit elevated compared to baseline. Once that happened, they trended back down to baseline, and they remained normal range through the rest of the observation period. The heart rate actually dropped back down a little bit after the initial increase above baseline. There were sort of more effects noted in the blood pressure measurements as compared to the heart rate measurements, more significance as well in the blood pressure graph. This next set of figures shows the results of the catecholamine assays they did. They found that dexmedetomidine lowered norepinephrine by 63 to 72%, epinephrine by 55 to 85%, and DHPG more modestly by 14 to 25%. Atipamezole, unsurprisingly, given what we saw with the blood pressure results, dose-dependently reversed the sympathoadrenal inhibition, and it overshot a little with the 150 microgram dose. More specifically, at the 75-minute mark, there was an 8-fold average increase above baseline of norepinephrine, and 140% increase of epi and a 60% increase of DHPG. So less prominent in the norepinephrine, but still an overshoot above the subject's baseline. Okay, so rounding out all of these various assays, this shows the pharmacokinetic results that they found. The figure A on the left shows the individual subject concentrations of dexmedetomidine and atipamezole in that first portion of the study where they were just looking at doses. You can see that we have basically pretty similar looking dexmedetomidine concentrations and a similar shape to the line of the atipamezole concentrations in all subjects. Graph B shows the average concentrations from that second portion. On the bottom, you see the dexmedetomidine concentrations in all four assays, the placebo and then the 3 atipamezole groups. And then the 3 lines above that are splayed out show the atipamezole concentrations for the different testing levels. The take-home from all of this is that the authors wanted to demonstrate that giving atipamezole at the same time as dexmedetomidine didn't seem to alter the area under the curve, the peak concentration, the time to peak, or the terminal half-life of dexmedetomidine, and that the serum concentrations of atipamezole were dose-dependent, but that elimination was dose-independent and demonstrated a half-life of 1.8 to about 2 hours. If you flip to the next slide, this shows just kind of the summary of the pharmacokinetic data they found based on all the measurements they took in their subjects. So the final question that they were investigating was the safety of both of these drugs in conjunction and in dexmedetomidine individually. In part 1, just the dose-finding portion of the test, they had 4 of 12 subjects report at least one adverse effect. All of these were considered to be minor. 3 subjects reported mouth dryness, 1 reported palm sweating, and 1 reported flushing and palpitation after atipamezole was discontinued. In part 2, 6 of 8 subjects had at least 1 adverse effect. Most commonly, these were restless legs after dexmedetomidine or tremor after atipamezole. All but 1 were considered to be mild to moderate. And then just as far as what was reported, there were 3 adverse effects reported in the placebo trial, 1 in the 15 microgram trial, 2 in the 50 microgram trial, and then 4 in the 150. So all of that said, there was one potentially significant adverse effect. There was one volunteer who 3.5 hours after getting the 50 microgram dose of atipamezole decided to sit up and eat lunch. So he was sitting up, suddenly reported feeling lightheaded, and he fainted and fell to the floor. He was unconscious for 20 to 30 seconds, and somebody was running to push atropine, and he woke up right before that happened. Of note, on the telemonitor, he'd had about a 10-second sinus pause recorded before he fainted. When he went to the ground, all his leads popped off of him, so they don't know how long that lasted. He was completely fine after that, and he actually completed the other sessions of the test. There was another individual mentioned who had a transient bradycardia to 27. That happened 2.5 hours after receiving the 15 microgram dose. So, putting all of this together, in conclusion, the authors felt that they found that in this group of 14 healthy men in a very controlled test setting, atipamezole seems to dose-dependently effectively reverse the effects of dexmedetomidine. They found that the 2 drugs had similar half-lives and that a single dose of atipamezole approximately 1 hour after administration of dexmedetomidine, which is a reasonably good recreation of how things would go in clinical practice, was a sufficient dose to reverse dexmedetomidine. They found that the pharmacokinetics of atipamezole were linear and that they didn't seem to affect dexmedetomidine metabolism. They did note a 3-fold difference in individual dosing, and they felt, though, that this was, if anything, a strength of the medication because it has such rapid onset. You could titrate rapidly to what an individual patient needed in order to wake up. They did find that the highest dose of atipamezole they gave caused what they called the transient but clear sympathetic activation. They speculated that this was rate-dependent. They didn't see this response in any of their initial dose-finding study in part 1, and the drug was given a lot more slowly since they were trying to really deliberately calculate dose in that portion. Everything, regardless of dose, in the second trial, all doses of atipamezole were pushed over 2 minutes, so they felt that maybe slowing the infusion would stop this, but they acknowledged that this is a potential limitation of the use of atipamezole because these guys were all, strapping young men, and if you're using this medication in a critically ill patient who might not tolerate the catecholamine surge, it might not be ideal. Then there's, the final question of safety. In general, most of the reported adverse events in this small group were simple things like dry mouth and restless legs. There was the one gentleman who fainted, and as we talked about in the other 2 papers, dexmedetomidine can cause bradycardia. they felt that it probably did contribute to what happened to the gentleman who had the syncopal event in this paper, although the fact that his event occurred 3.5 hours after he'd gotten the drug, and the fact that he later said that he was apparently a fairly frequent fainter, particularly in medical settings and when he saw blood, they felt that likely could minimize the effect. Although, you know, he also had just sat up to eat lunch, and alpha-2 activation certainly can attenuate a physiologic response to a postural change, so it's possible that he developed severe orthostatic hypotension as a result of having some lingering dexmedetomidine on board. And that's kind of the end of that paper. And, yeah.
So I'll see if there's any questions, comments, thoughts from everyone out there listening. You know, first of all, I guess do people see that there potentially could be a role for something that can reverse all the drugs we talked about today, not just dexmedetomidine for sedation purposes, but the pediatric clonidine overdose at the outlying hospital that otherwise might get intubated, the Xanaflex overdoses in adults, et cetera, the intentional veterinary overdose of xylazine, which we occasionally see, sometimes with lethal purposes. So.
Yeah, this is Rob Hendrickson. I'm actually curious because you know, we have all these overdoses, and it's basically supportive care. But if you look back at the literature, there's a whole parade of alpha-2 antagonists, tolazoline and idazoxan and yohimbine, who have all been used previously to reverse. I'm just curious if anyone out there is doing anything different than I am, which is just supportive care, and you know, let them recover and metabolize. So if anybody is using any specific therapies, I'd be very interested to hear that as well. And then, of course, the question with these ingestions always comes up is naloxone or no naloxone.
You know, I think naloxone kind of crept in there as a maybe works kind of thing. But I mean, most of these papers have been underwhelming. Let's see, we have a hand. Phoenix?
Hello, just trying to, hi, it's Michelle again, just trying to help give you some feedback from some of the comments around here. Well, with the alpha-2 overdoses, you know, obviously most of the time they don't even require intubation. I mean, that's so rare, but we just give supportive care. There's nothing specific that we use. And then we were just talking about, I did forget to say earlier that the pediatric intensivists do like dexmedetomidine, and we have seen it and used it with several of our intubated scorpion patients over the last couple of years. And that's probably the only role that we've been using it with. With the adults, we just don't really see how it's really better than any other drugs right now. And one of the comments that was made regarding the first paper is it would have been nice for them to have a control group where the children actually received a drug that, you know, say if chloral hydrate's the most commonly used drug right now for sedation, maybe one group could have gotten chloral hydrate and the other group gotten dex, and those be compared. But so far, I don't know that we've really seen any good evidence for dexmedetomidine for anything in particular.
Yeah,
I think
it certainly seems like if you're going to use it, it would be a group that's hyperadrenergic to begin with, so that the hypotension or bradycardia would be therapeutic, as opposed to, you know, someone with normal vital signs or low vital signs to begin with. So, thanks.
Right, and I think that's why we sort of agree with using it for our scorpion stings.
Yeah.
But it is pretty expensive too right now.
But does it spare you having to intubate the more serious scorpion envenomations?
I'm sorry, what was that?
I mean, the idea behind this dexmedetomidine is the airway protective reflexes are still intact, and you don't necessarily need to be intubated if you're getting dexmedetomidine. So on the most severe pediatric scorpion envenomations, does it spare them from needing to be intubated, you know, just on an anecdotal basis?
No, but I have to say I don't think we've even tried to use it unless they've already been intubated. Usually when they're to the point of intubation, it's because their airway, it's not because of the hyperadrenergic, it's because they need airway protection. So otherwise, a little benzo and opioids will usually fix everything else.
Very interesting, thanks. So, Rocky Mountain, you have your hand up too. We'll unmute you. Okay, you should be unmuted, I think. No.
Rocky Mountain?
Pardon our technical difficulties. We're trying to figure out how to unmute. Looks like you're not muted on our side, so if you can check it to see if you're muted on your side, that'd be great. Unmuting those three. Yeah, okay. Anybody there?
Hello?
Yep,
Yeah,
go ahead.
There we are.
Sorry about that.
Yeah, no problem. So this is, we really haven't used it much either. We're sort of echoing what Michelle was saying. We've had some interest in a couple of the departments using it for alcohol withdrawal, but you know, we've generally relied on high-dose benzos and propofol. You know, and we had a couple of years ago had a massive clonidine overdose that involved a compounding pharmacy where a kid got 100-fold dosing error. And I have to say, I'd echo what Michelle said, which is really, we were able to get the kid through pretty well with supportive care. And I think that, you know, that it's going to be difficult to get this kind of drug through and approved. On the other hand, it is certainly nice to have something that you can use sort of long-term with the quick wake-ups. And I do think that, you know, that's where we're seeing it used, and is in our ICUs more for sedation when they want to have the quick wake-ups. But I'm not sure, at least from our practice, that it's really affected much of what we're doing.
Do you have any, I know this has come up sort of in a separate setting in the emergency room with sort of the new Center for Medicaid and Medicare rules about who controls and privileges sedation, and some institutions have taken a very hard line that certain drugs like propofol and etomidate are really anesthetic agents and really need to be under the complete bailiwick of anesthesiologists. And the necessariness of having two people in the room, which our institution does abide by too, one to do the sedation and one to do whatever the procedure is, whereas this drug sort of is in this gray zone right now. I almost feel like it's kind of like the people who come up with these new drugs to abuse, they figured out a way around the rules. It's dexmedetomidate. We've borrowed a page from our drug abusing population to get around the rules of etomidate and propofol and things like that to perhaps figure out a way to sedate patients in a different manner. I don't know if that's an issue out there with you or with anyone else. I mean, it's not that much with us, but I know in some institutions that has become a major point of crises.
It hasn't really been an issue for us, fortunately.
All right, well, just want to thank everyone out there for listening in and participating. Really appreciate it. And I think that's about it. Unless anyone else has any more comments, we'll sign off. Thanks for listening.